My name is Frank Platt, and I'm a licensed clinical social worker that came to Florida almost 30 years ago to go to FSU, and in between then and now, I've worked with both in private practice out in the community, was the community children's mental health analyst for the state of Florida, and then the behavioral health manager for Florida Child Welfare for a couple of years, and then I retired, and we got a system of care grant, which you're probably familiar with. And these are expansion grants, which is a 4-year expansion grant to expand the use of system of care values for children's mental health in Florida. And the site that I'm responsible for is Gaston and Leon County. And our target population is the birth through 8 years of age group. And so that's what we focused on, which is very different than a lot of the sites, because a lot of sites, they'll be focused on kids aging out of child welfare, aging out of children's mental health, aging out of DJJ services and stuff like that, which is a very different focus. Because what our focus is child and family well-being. And what we believe that if we work with families that have kids that have different types of challenges, either developmental, physical, behavioral health, social emotional challenges, if we can work successfully with them when they're young, then we're going to have a lot fewer kids when they get to be 8, 9, 10, 12, 14 years of age that are showing these disturbing behaviors that we call children's mental illness, which, because very few of them, in my experience, are really bipolar, schizophrenic, but they have some behaviors that they've learned that are very antisocial behaviors, but they work for them. And so what we want to do is help parents raise their kids successfully, to be as successful as they can, no matter what their challenge is. And again, we figure if we do that well, then we're going to improve the trajectory for that child and for their families. And one of the things we learned as we went along, because initially we were just looking at that 0 to 8 population and their families, and we really weren't dealing with the older kids, that 13 to 18-year-old group. But what our understanding as we did that is that if those kids have challenges, those are also kids that are going to have babies. And if they have challenges and they have babies and we haven't taught them how to be okay themselves, then their babies can't be okay. Or they have a lot harder to grow of it. So we've started over the last year working real closely with a lot of those youth groups. So anyhow, that's kind of introduction of what we are going to talk about. And what we're going to talk about is creating a trauma-informed system of care using system of care values. System of care values are being that the service system has to be family-driven, youth-guided, community-based, and culturally and linguistically competent. And we can talk more about what that really means, because those are kind of neat catchphrases. But you got to do all three of those together to really empower families to raise their kids. You got to be family-driven. You got to be culturally and linguistically competent, and you got to be community-based. It's the only way it works, we think. And I don't know who we are, but we think that that's the way it works. So anyhow, let's see what we got. Okay, trauma-informed care is an organizational approach to programming that understands and anticipates and responds to the behaviors and expectations of getting out of here. Expectations, kids have been traumatized. You can read this definition, and I got a couple of definitions on here because I always feel that it's important that we understand when we're talking about a subject as broad as this, what part of that we're going to be looking at. Okay, so there'll be a couple of these. I promise not to read all 100 and whatever it is slides that are in that presentation. And you'll see that some of those, I always put a lot more on than I actually go through on this thing, because I like people to have a resource to look back at and to get some ideas. If something we say kind of, with me, I process things a couple of days after I've been to a presentation or something, so it's nice to have something to go back and look at that. So if I say something that doesn't make any sense to you, please feel free to raise your hand and say that doesn't make any sense to me. Okay, so we can discuss it, because what we're really doing in all of these system of care expansion sites and this notion of a trauma-informed system of care, it's really stuff that we're really trying to figure out how to do that, and it has to be done locally. You know, all problems are local, right? No matter where they're trying to solve them, all problems are local. And how you implement this whole philosophy of understanding trauma and what it does to kids and to families and how they deal with that whole understanding has to be dealt with locally. But we can certainly talk about that. So we're going to talk a little bit about the ACEs study. Do you all know what the ACEs study is? You know, I'm sure you know it. You don't know it? Okay. Do you all know what the ACEs study is? Well, we'll mention that briefly then. We'll talk about what is trauma, what's a childhood system of care, what's a traumatized system of care, and what the elements of that all are. Talk a little bit about what when we talk about family-driven care, what do we mean by that? And then we're going to look at the history of our expansion site, which is we're now calling the Whole Child Leon-PACT Partnership. Do you know what the Whole Child movement is in Florida? The Whole Child is a movement that Lawton Child started many years ago now. And it really, they talk about the whole child. What do you need to do in a community to raise a whole child successfully? And what we found when we first were looking at how we wanted to partner in the community, that for an early childhood system of care and the whole child philosophy on how you raise kids to be healthy and successful, they really are very similar. And so we've been able to partner with Whole Child Leon, and we'll talk a little bit more about that. But that's how we've been able to focus in our community and actually start to do some pretty neat things in our community. Now we're in almost to finish the third year of our grant, and so we have one more year to go. So we're also looking at how do we sustain these gains we've made with providers past this 4-year grant series. In other words, how do we institutionalize what we're trying to do so that when the grant money goes away, which isn't, basically the grant money pays for me. That's all of our grant does. I don't know if your grant's, is yours an expansion grant too, or is it an over grant?
It's something that they've been using for the 5x5, so I'm not sure.
Where was it?
In Volusia County?
Volusia? Okay, that's the new one. Yeah, no, that's an expansion site. Okay. Volusia, Flagler, and the 4 counties. That's the expansion grant sites that came with this, with what we're doing right now. And they have a great family program down here, as you probably already know.
I know that some of the things that you just talked about, the family, I mean, so it's even involving organizations like Mine Number None. We don't focus on children, we focus more on the adults and the parents, but it's still involving all those agencies to make those assessments.
Right. Well, you know, and the thing is that you know, the people that are as old as I am, and when I went to MSW school, they really, even in the social work, we were looking at the environmental perspective, but we still thought a lot about treatment in the medical model. Whereas you had a person that had a problem, and you were the expert, and you were going to fix that problem. Well, if you've ever really done that, you know it doesn't really work very well, especially with kids. Because why? Kids function in an environment, and the environment has total control over what goes on with that child, right? So if you have a child that has challenging behaviors, and you don't work with the environment that child lives in, then you may get the child to stop doing that particular thing, but since she hasn't changed the environment, something else is going to come out, right? That's just what it is, because the behaviors of that child are probably just kind of the outward manifestation of whatever the problems in the environment that child is living in. So you got to impact the environment, which means you got to impact the appearance. But anyhow, so that's what we're going to talk about. And why are we talking about this? Well, one of the reasons we're talking about this, of course, is trauma is pervasive, right? And when we, you know, the history of dealing with trauma is really rather short. It really started after, a little bit after World War II, but more after Vietnam, with post-traumatic stress disorder, and then starting to understand that people in the community also had, you know, PTSD or manifestations like that, and it's kind of gone to where now we're starting to really see what the whole influence of any type of trauma that a child or a family is involved in, what that influences them on how they function in their world. Okay, so we're getting to have more understanding about that and understanding what the different areas trauma can actually do. When we're talking about a traumatized, child or even adult or system, there's three words or phrases we have to really keep, in mind. First of all, we got to make things safe, right? Safety is the first thing. We all remember, well, we may not remember, but if you know Maslow's hierarchy of need, which really does work. With kids that have been traumatized, kids that are in stressful situations, if they can't get out of those first two levels, which they can't, right? They can't get up there to feeling good about themselves, and self-actualization, all that kind of stuff, because the basic needs of getting the food and shelter and feeling safe, if those aren't met, and even if you think you're meeting them, but the person you're working with doesn't recognize that, then you can't get to those higher functions, right? So you've got to make sure that's done. We have to give them sense of empowerment and power, right? And the reason for that is one of our problems with trauma is people get to feel that they have no power, they have no control, that everything is happening to them and they can't be okay. So one of the things you want to do is make sure that we're giving them a sense of control and empowerment. And then third, that we have to give them hope, right? Because the other thing that people that have been traumatized don't have is they don't have a sense of hope for things being better. And if you don't have a sense for hope for things being better, why should you work on being okay, right? So those are the three phases that we always try to keep in front of us. Now we know that 25% of children and adolescents in the community experience at least one potentially trauma event in their lifetime. And of course that came out in 2002. And then more recently, we had the ACEs report, whatever, the ACEs study. And that was done in 1995 to 96 is when they did this. And this is Kaiser per minute. I can never say that. Anyway, they had 17,000, it's a health plan in California, and they had 17,000 of the folks that are in their health plan do this study on traumatic events. And what they found is that 63% of them had at least one traumatic event in their life, and 20% or more experienced 3 or more. And what this ACEs study found is that the more traumatic events you had in your life, the lower life the lower life expectancy, I can't even talk at all straight today. Huh? Did I have it up there?
Yeah.
See, look. Yeah, the significant consequence of providing more health problems. Some people think that it's just physical or mental health problems. It's physical health problems. That there's more diabetes or more health, heart problems and whatnot. So people that had these 3 or more traumatic events in their life, really, that they died a lot earlier, and they had a lot more physical health problems and mental health problems. So that's why that's important. We also need to know, what do we mean by child well-being? This is how we define child well-being. The child attains physical, intellectual, and spiritual well-being. We can talk about what that means. Spiritual well-being doesn't mean that they go to church. Okay, people get worried about that word. What spiritual well-being is how do you fit in the world? How do you impact the world? How are you okay in the world? And that's that spiritual understanding of the world. And there's different ways people address that. That experience strong, positive family attachment, interacts constructively in a social context, sense of hope, which we've talked about, and lives in an environment that encourages him or her to succeed no matter what challenges they have. That you have to believe that no matter what challenges this child and this family have, that what our goal is to allow them to reach their maximum, efficiency in life, right? To be as successful as they possibly can, and everybody can be successful. It's just that you have to have an understanding of what the challenges are and how you can impact the world and how you can fit in the world and how you can be an important part of that world. And when you're doing that, then part of it also has to be working, of course, with kids, working with the families to understand how to do that with their child. and make it okay for them to do that with the child. Okay, so what is trauma? And I love this definition. Trauma is when people live with more fear than hope. And it's a fear for their future. It's a fear for, am I going to be okay? Are my needs going to be met? Right? And we want them to have hope for the future, that things are going to be better and that they can last. Now I'll let you read. This is Samson's definition. And the only thing that you might want to add to that kind of a definition is that trauma is an experience that somebody has that's unusual, that's unexpected, and that overpowers their ability to cope with it. And that last part's important because that's different with each person. Okay? Because the way people cope with trauma, a lot of it depends on their personality and their past experiences and how they've learned to cope with the challenges in life. And that's why, for a bunch of years, they talked a lot about resiliency and recovery, and we still talk a little bit about that. Well, those are the factors, building those resilient factors into kids and families helps them cope with trauma, doesn't it? So the better that we have built this resiliency, not only in the kids, but in the family, because if you build resiliency in the family, you build it in the kids, right? And the better we do that, then when that traumatic event comes along, the better they are able to handle that. And so the trauma is devastating to them. I think we've probably talked about it. See, I'm not going to talk about all these. I talk about all of this sooner or later, I think. But anyhow, the child's response to trauma will depend on their age, developmental, their physical age and developmental age, their temperament, perception of the danger faced, and again we go back to, we look at the resiliency factors, which we'll talk about a little bit about the family resiliency factors later on. The child that has had long-term trouble or trauma has an ability or disability to trust, they can't trust others, they have a poor sense of personal safety, their ability to manage emotions, that whole the self-regulation issues, depending how young the child was when the traumatic events happened, and we'll talk a little bit about what those traumatic events may be, because it's not necessarily what we normally think of as being trauma. Okay, there's some things that some kids can suffer an awful lot of problems, but not be traumatized by it, and some kids, something we think was kind of a mediocre, big deal type of a thing, but is very traumatizing to that child. And so we have to keep that in mind when we're talking with the child and with the child's parents. And traumas can occur from a whole bunch of different things. We say here it can be a car accident, significant health concern, and that could be the health concern of either the child or the parents. That if the child has a parent that has a severe, a serious health concern, goes off to the hospital for a period of time, that can be traumatizing. Of course, the death of a loved one. Yeah, did you have a question?
Would you consider institutionalization a form of trauma? Like going from group home to group home to group home?
Yes. Well, yeah, we're going to talk about that. Let me.
Okay.
One of the things, that's okay, because we can go all over the place for one, and I do that sometimes. One of our problems when we're looking at a trauma-informed system of care is to eliminate the institutionalized trauma that kids suffer. And if you look at how we traditionally take care of kids, and a lot of our systems, child welfare, the schools and whatnot, re-traumatize kids.
Exactly. Something
fierce. They really do. I can still remember one kid who, one kid who was an infant, that in the first 6 months it had 4 different, placements. That's traumatizing. Right, and of course,
15 in a year.
Right, and that's traumatizing, and the system didn't realize that. And you can even get some people who propose that they are experts in children's mental health issues that feel that if something happens to a kid before they're verbal, when they're pre-verbal, they could not have caused trauma. And then that's because they don't have any words. This is their theory. They don't have any words to express it. Now, if you understand play therapy, the reason you do play therapy with young kids is because they don't have the words to explain what happened to them, but they do have the actions. to explain what happened to them. And so you want to get that because even as young as they are, one of the things you want to do is help them get whatever that is out in front of them so you can look at it. And then you can help them understand what that was, and that's not something that's going to hurt them now. This is, in one of my previous lives, I worked in private practice in a couple of different ways, but worked mostly with traumatized kids. And I had one kid I was working with, and a lot of them were served by child welfare, DJJ, and one of these kids that he had already failed 2 adoptions. And I thought he was a delightful little kid, but he had a lot of questions about whether he could be okay. And each of those failures of his, even though in the traditional sense of trauma, he hadn't been to war, nobody had beat him up, he hadn't been in an explosion, but the trauma was that what you expect out of life when things happen that go against that and are outside what we normally expect life is supposed to be like, and then our abilities to handle that are really taken away from us, then that's trauma, right? And one of the other traumatizing acts is the zero tolerance policies in school systems. That's very traumatizing, right? The thing that where we use seclusion and restraint in schools, that's traumatizing. When they use seclusion and restraint in inpatient psychiatric facilities for kids, that's traumatizing. In part of the theory, so I worked in there for a while, part of the theory there was that these kids are totally out of control, and so what we're going to do is take all control away from them, and then they have to earn their control back. And of course that didn't work. And we didn't understand that a child's been traumatized, that you don't put your hands on them if you don't want them to act out. Because what you've basically done with that child is say, okay, I touched you, and now it's okay for you to touch me. Basically what you've done. And the idea is that we don't really, my understanding is that we don't want to take their power away from them. What we want to do is empower them. Empower them to be responsible for themselves and to take care of themselves as best as they can. And our job, as we'll talk about a little bit later, is to help them learn how to do that, but not do it for them. Okay, when you do it for people, then what they do is it becomes a lot easier to let you do it then, right? That, okay, you want to be in charge, you're in charge. Right. Yeah, well, and some of the kids, they tell you when they really lose it, so they really go bonkers, and you say, why did you do that? They say, because it was so much fun. When they totally trash something, trash the room or trash the common room or whatnot, because it was so much fun in that they were in a position where they had lost all their privileges and everything, so there wasn't anything else to lose. So instead of being responsible and learning how to do that, it was just more fun to just let it all go.
I got a lot of attention for it.
Oh yeah. Well, one of the things you see with a lot of kids that especially have some challenging behaviors is they're really good at getting adults to act out. And of course, when you do that, and that's another lecture, but when you do that, what they're doing, you see, is especially the little 4-year-olds, that what they're doing is they're getting the adults to act out, so now they are in control. You see, if I can get you to act out, then I'm in control. Now they don't really want to be in control, but that because of how their safety notion works, that somehow is a good thing, but it's not. So it's kind of a mechanism to make it harder for that child to be responsible and learn how to be responsible. And that's really what we're trying to do, is raise kids that are responsible and make age-appropriate decisions, right? We don't want the 4-year-old to be making, 18-year-old decisions, but we want the 18-year-old to be making 18-year-old decisions. Does that make sense so far? Okay. And you can read what these all things are all about. The thing we have to look at is lack of shelter and food is a traumatizing event. Hospitalization, of course. Poverty is a traumatizing event. One of the things that we've started working with real close in our area is with the homeless programs. And what we found is that it's kind of interesting because we're also right now that we've just in Tallahassee they've just developed what they're calling the Comprehensive Emergency Services Center, where they close the homeless shelters downtown in Tallahassee, and they open up this new, over $7 million facility for homeless. But of course they can't serve families there, and we have another facility that serves families. And it's very different from serving the adults that are homeless and serving families that are homeless. And the challenge is how do we promote good early childhood development for those kids from families that are experiencing homelessness. Is something we're going to be working on over the next couple of years, because that's a traumatizing event, both for the child and for the parents. No, we don't want that. I have a terrible time getting this thing to work. There we go. Okay, well, this is again, this kind of goes back to what we were talking about before, that how anybody deals with trauma, also it's affected by their cultural beliefs, right? That some people, that in their culture it's okay to go outside of the family to talk about problems. Others, you're supposed to deal with that within the family. But we also know that a lot of the issues that we have to deal with are intergenerational. And so when we're dealing with an intergenerational problem that is contained within that community, and it can't come out to the wider community, then it's a lot harder to impact that. And we have to figure out ways to help them do that. Okay, we've talked about that. Just to know the difference between trauma-informed, the definition of a trauma-informed care and a trauma-specific service. And again, when we're talking about trauma-informed care in the system, it's knowing all the elements that come together to make that trauma an issue for that family. And you have to deal with each family or with each group at a time. And it's not necessarily the service, but it's how the organization, how the community comes together to provide services. Of course, you've probably heard this before. It's the question always is, how can I help right now, and not what's wrong with you, but what happened to you. And this is a different way of thinking about these things. It really is, because this goes back to, remember we said that this is a family-driven thing. And when we say family-driven, what we're saying is what happened to you, and what can I do to help you overcome that? Okay, not what kind of problems do you have, and if you do what I tell you to do, you'll be okay, which is kind of the traditional way. I can still remember so many treatment plans, so many case plans in child welfare that the case manager, the therapist wrote it, and the client, and I hate to use that word, client or customer, but the person you're working with, that they were not a good, they weren't a good partner if they didn't do what it is you told them to do, right? And of course, part of that understanding was that we knew what they should do to be okay, so we didn't really want to hear what their opinion was. And if you get down to really what it was, and I think it also got to that this is how we know to do it. Okay, and it's a lot harder to say to that person, okay, what happened to you? And the other part of that, though, is what have you done successfully to be okay, as okay as you are? That's the other part of that. Because what do we want to do when we're treating families that have trauma and aren't functioning real well? We don't want to come from a deficit point of view, do we? We want to come from a strength point of view. And a strength point of view says, what are you doing well, and let's build on that. Okay, not we want to correct all your problems. Because if all we're doing is saying we're going to correct your problems, then what they're hearing is, I have all these problems and I'm never going to be okay. And remember, we go back, what are we trying to do? We're trying to empower them to be responsible for themselves and give them hope that they can be okay. And the only way they can be okay is if they're okay, not if I'm okay. Okay, if I'm working with them and I'm okay, that has nothing to do with them being okay, does it? But sometimes we seem to think that's what it is. But anyhow, I digress. We've talked about that. But here's the 4 R's that we have to understand when we're looking for trauma-informed care. First of all, realization that trauma affects families, groups, that it plays a big issue in mental health and substance abuse issues, and that one of the things we often have to realize that everybody in that system that's dealing with this person or this family that's been traumatized is affected by trauma, is affected by that trauma. And of course, we have to understand what the system, what trauma looks like. And you can just, these are kind of the symptoms that this is showing. You're kind of the things that you think about when you think about post-traumatic stress disorder, don't you? But if you think about that, when you think about post-traumatic stress disorder, there's a lot of people that show signs of trauma but don't have full-blown PTSD. But they do have some of the flavors of these things you see up here. The avoidance behavior, the startle reflex, the things like that. And sometimes it's really hard when we understand their story, why they're reacting the way they are, right? But again, we don't really want to judge that. We just want to use that as a way to have an idea of what's going on with them. You have to understand how people respond. And I think that this center part here, when we're talking about a trauma-informed system of care, or trauma-informed organization, the person that's most important in that organization when that person comes to get help is the first person they see. Okay, that intake person, if they come into an intake desk or something like that, if that person is not greeting and accepting and there for them and lets them know that this is a good, safe place to be, if they don't get that from that first person who they come into the door, then it's really going to be hard for them, and a lot of them will turn around and leave.
And they're the lowest paid, lowest educated people usually go.
Yes, right. Well, it's kind of like, that the people who work, the staff that work in a lot of our hospitals and whatnot are the lowest paid people too. And yet they're the most important. The doctors and nurses and all that, they're important, but it's the people that deal with this person day in and day out. And that's why it's so important when we're talking about a trauma-informed system of care and talking about for kids, that we empower the parents to raise their kids. Because you can be the best therapist in the world, but you're only going to see this kid for an hour or so a week. Mom and dad have them for the rest of the time. So it's how we impact that system to be a more therapeutic system to help that child and to also deal with the trauma from that family that's going to make this thing work. And of course, we talked a little bit about the understanding things that re-traumatize kids. And we had some good examples. A bunch of years ago, we were doing an initiative, we meaning the Florida Child Welfare Behavioral Health side of the world in Florida Department of Juvenile Justice. We're really looking at the issues that go on with kids that have been, that are in some of their deeper DJJ placements. Because we had that notion a lot of these kids really had behavioral health issues. They really weren't a bunch of budding criminals. And so we came down to DeSoto, which was a level 8 DJJ facility for girls, but it was a mental health facility. And what we did was kind of a unique thing, is we actually asked them to come tell their story. And we had their DCF caseworker and their DJJ caseworker tell what was going on. And what we found was most of these kids had been traumatized as a child, and something had happened to them to get them in trouble, usually at school. And they'd gone to detention, something had happened to detention, and it just escalated. This one kid that we were talking to, very articulate young lady, and she had been severely sexually abused. She was at school in the hallway one time. The school monitor, had been a coach or somebody, came up, put hands on her, put her up against the the wall. What do you think a severely sexually abused girl is going to do when somebody grabs them and throws them against the wall? She smacked them. So they call the school resource officer, comes down, he puts his hands on her, she smacks him. Next thing, she's at attention. She goes into, and this is her story. And it was a true story because we knew her history. Same thing had happened to her in detention. So within a year or so, she had a rap sheet about this long, where if somebody had just understood that she was a victim of trauma and how you approach somebody that's a victim of trauma. It doesn't mean you let them do whatever they want to do, but there's ways you approach them that doesn't put them in that fight or flight mode, which doesn't allow them, once they get there, to rationalize what's going on and figure out, okay, what do I do to be okay in this situation and what's really happening, right? And if they had done that with this young lady and a bunch of the kids that we talked to, then they probably wouldn't have been there. But we had this zero tolerance, this you have to do what I tell you. And of course, the police have the same problem, is that you have to do what I tell you. And this is why that was it CIC training? Is so important for police departments, is because it teaches them how to deal with somebody that may not be being disrespectful, may not be really being threatening, but that are reacting the only way they know how to react. And how do you actually deal with that? And unfortunately, in our area up around Tallahassee, our Tallahassee NAMI has trained over the last couple of years about 500 police and sheriff's deputies in our area in CIC. And that really works. Okay. How are we doing? I got to get moving along, don't we? Okay, and I think we talked a little bit about this when we talked about the understandings of the world people have, is that their cultural understanding and their cultural framework affects how they deal with trauma. We have to understand that in a traumatized system of care, trauma-informed system of care. Customer voice is important, and again, if we're looking at a family-driven system of care, we have to hear what they have to say, and we have to put them in the driver's seat. Of course, this is what family-driven care. The way I like the definition of family-driven care, I think, is that the family are the guys that are going on down the road, and the family's in the front seat, and they're the people that are driving the car, and that the professionals, mental health professionals, and others are the folks that are sitting in the back seat. They've got the road map, and they're helping them figure out how to get to where they're wanting to go. But it's still the driver's responsibility to get there. And I think that's the best way to look at family-driven care. It's in a way, it's giving up that power of, I'm a great therapist, or I'm a great whatever it is, and if you just do what I tell you, everything would be okay. And it's saying that I really want to understand what's going on with you, and for you to understand that, and for you to be able to, whenever this happens again, to be able to get yourself out of it. Okay, we're trying to work our way out of a job. Well, we won't, but that's what we're trying to do. I think we've probably talked that to death. We talked all that to death. Do you have any questions about what we've talked about so far? Because what I want to get into in the last couple of minutes here is what our experience has been in Northwest Florida. Now, I think one of the things that we have to look at when we look at what we do is that here are kind of the things that a system of care, and trauma-informed system of care, should be doing. In the red there is telling us how we're doing it, or how we're trying to do it. So to get the message out there, that's that public awareness, that's the social media type of a thing. Strategic partnerships, of course, are important in any system of care. As a matter of fact, because we need to get on past that and go to what we're doing here. Our vision for our Whole Child Leon-PACT Partnership is empowering families today to encourage healthy and resilient children tomorrow. Their mission is to build community-wide collaboration and support and investment that empowers families to promote their children's resiliency and social emotional well-being. Those are good God and country statements, aren't they? And of course, what we're trying to do is operationalize that. We've talked about our target population. these are the goals that we're looking at, and of course the first one, when we're dealing with a 0 to 8 population, is that the child is healthy by year 1. Okay, we also want to make sure that when they're ready to enter school, which is the voluntary pre-K now, that they're ready to do that. And a lot of that is dealing with the behavioral awareness, the social-emotional development, their ability to learn. And of course, all those things are affected by what? They're affected by the environment, aren't they? All those abilities, all those things to be ready to first of all be healthy at year 1 and to be ready for school at about year 4 are based on those lower 2 elements of Maslow's hierarchy of need. Are their physical, needs being met? Are their safety needs being met? Or is that relationship that they have developed with their primary caregiver, is that good? Okay, all those attachment issues. So all that thing is self-regulation working with this child.
So why did you choose to go to the age of 8 instead of 5?
Why did we go to 8?
Mm-hmm.
Well, usually you think of these things are the birth to 5.
Mm-hmm.
But what we want to do is we want to make sure that kid is healthy up through the 2nd grade. Okay, because if we have a child who's being successful in school in those first couple of years, then the probability of them doing well up through elementary school, middle school, and high school is greatly improved, and the ability of them to graduate is greatly improved. The kids that are failing in those first 2 years, if you don't learn those basic principles of reading, writing, and arithmetic in those first couple of years, it's a lot harder to catch up on that later on.
Well, I've heard, if they're not at a certain point at grade 3, their predictions
are terrible. Yeah, they really are. And so that we think that that's really an important element. And that's why we did it that way. Let's see, we talked about that. And of course, the reason we're saying this is a trauma-informed system of care is because of those system of care values that we're instilling. Because by doing that, we're instilling, first of all, we're making sure that they're safe. We're instilling that empowerment of the parents to raise their kids, and we're giving them hope. Here are the different agencies and providers in our system of care that are working with Whole Child Leon. And this is important because what we really have here is just about, there's a few, we're missing a few yet. We have about 40 different agencies that serve Gaston and Leon County that are working with us to figure out what this is and how to do it. Okay, now of these 40, there's 29 of them that have actually signed a memorandum of understanding with Whole Child Leon to support Whole Child Leon in what they're doing, and that grows. The latest one that we have is the Healing Transitions, which is a mental health provider in our area who's really recently started doing a lot of work with infant mental health.
And do you have more health plans on there?
Now we have 3 health plans on there. 4. Well, we have Magellan, in Magellan really, they are the most active with us. But we also have Sunshine, who, and the lady who's the Sunshine person is going to be really running our cultural linguistics competency work group here in the near future. And we also have Prestige. But who else do we have? Those are the only 3 we have. Because Sunshine and that other one, they're related to each other. It's the same plan. Huh? But anyhow, when we think of what you do in an early childhood system of care to promote well-being, we look at it's a 3-tier service system. You've probably seen things similar to this. Usually they show it in a pyramid, but we like to show it in these bubbles. And I just use this because this is the first slide that we showed when we were talking with the Whole Child Leon board to explain to them what we were trying to do and why we thought that worked. And you can see there's the 3 different levels. The first one is kind of the universal, getting folks in the community to understand what all the different issues on child well-being is and what they can do. That's just social media. That's some real low-level services and whatnot, and that should be about 80% of what you do. That the second level is the screenings and assessments and the early intervention types of services that you do, and that should be about 15%, and then 5%, if you've done these first two well, that only 5% of what you do is actually going to be the hardcore, what we think of as behavioral health services. And the better you do these first two, the fewer kids you're going to have in the third one, and which serves the community well, because first of all, we're going to have less money that we're having to spend on these higher end kids, but we'll have less kids to spend the money that we have. And so we can provide them better services. But our whole hope is that if we do these level 1 and 2 better, then that overall our community and our families are healthier. And one of the premier things that we've done for a couple of years now, is an early childhood screening. And when we do that, we do the traditional early childhood screenings with fiddlers and with CMS and whatnot. But we also do the hearing and vision screening, and then we have the providers that are also on site, that if we come up with a concern about a child, we can take them directly to that provider, who can then schedule them to either have further assessments or to begin services. And that's really important, because what you find in these systems, that if you have a concern and you say, Mom, we have a concern about Johnny, this is what it is, and here's the person to call, and please call her and set up an appointment, and that really very rarely happens, right? But if you take them to somebody and they can start that personal interaction right there on the site, we have a much better chance of the parents being able to follow through for a number of reasons. One of the things that we talk about, and the reason I've started talking about this is I started doing this presentation a while back and didn't really, I was just looking at doing it for a trauma-informed system of care, that theory and what that looked like. And as I was looking at that and understanding what we've been doing in our Whole Child Leon-PACT Partnership, that it really was meeting those needs of an early childhood trauma-informed system of care. And that was because of the things that we did. Is you may be familiar, if you're familiar with child welfare, you're probably familiar with the 6 family protective factors, right? And those are the factors on how you build resiliency in a family. Okay, a whole child has the 6 dimensions of a healthy child. And when you look at those two, what you see is that they kind of mirror each other. They look at it a little bit differently, right? Because the 6 dimensions of a healthy child are more of a, that's really nice, feel-good type of things to say. And the 6 family protective factors are a little bit more hardcore type of stuff, right? That's the best way I can explain it. But they go together because they're saying the same thing. And if we have time, which we really don't, we can talk more about that, or there's a lot more discussion in your handout about what those things are and how they work. And here is what the 6 protective factors and the 6 dimensions are. Of course, nurturing and attunement or attachment, that early attachment is so important, right? And how you watch what's going on with the family and help them to understand how to, in fact, get that bond between the primary caregiver and the child working better. The social connectiveness of the family is critically important. And well, you see with the kids that have been abused or in a number of ways, and really when we talk about kids in child welfare, that the majority of them in child welfare have not been physically abused, it's more of a neglect issue than it is a physical or sexual abuse issue. And that neglect issue comes from a family that's not functioning very well, right? And a lot of their functioning not well is because of lack of social connectiveness. Okay, but you can read what those are, and then you look down here at the 6 dimensions of the healthy child, which is the physical and mental health, the social emotional development, the economic development, safety, and these things all kind of go together, and they reflect the 6 protective factors from the family, or the 6 family resiliency factors, which is another way to say the same thing. And of course, if these are what you're trying to get into a family, and then you do that using those system of care values, right, of being family directed. In other words, we want the family to be in charge of this, right? The family makes a decision for what they're going to do and how they're going to do it, and our job is to help them figure that whole thing out, that it's going to be community-based. Whatever we're going to be doing is going to be within the community, not outside. We don't teach people how to live in the community by putting them in residential treatment. Yeah.
I'm just thinking about District 11, Miami-Dade, and the Keys.
Oh, yes. Know them well. Is that where you're from?
Our wonderful judges
Yes.
like to dictate. So for them to buy into the system of care values where the family drives their case plan along with the youth and is community-based and culturally, linguistically competent, it's going to be very hard.
Yeah. Yes.
They like to dictate. I could tell you our case plans look very cookie cutter. Everybody has the same case plan, you just change the name. So what would you recommend for that buy-in?
That's difficult. Who you get to buy into, though, is the Guardian Ad Litem program.
The Guardian Ad Litem is a very, very good at driving that as best they can.
Well, in my experience with the Guardian, with the judges up in our area, it's up, on one side or another, been the Guardian Ad Litem for a couple of years now, and then before that, I was on the case management side in courts. And our judges always, no matter what we think of them and what we think of some of the decisions that they make, because sometimes we get the same thing, it's my way or the highway.
Yeah, it's very resistant.
But our judges always said, GAL, what do you think? And we have a good relationship with the judges that if we really think something is important, that they listen to us. But it is difficult.
The families to talk to their GAL more so that the GAL, it has that more active voice.
Yep. Well, and to do training with the Guardian Ad Litem. I do the training with the Guardian Ad Litem on children's mental health issues, and I did this trauma-informed care training with them. And it's important because it's important to realize that most of these kids, and really most of the families that we deal with, they're not bad, and they're really not mentally ill. It's that they don't know how to do better. And what our job is, if we really want to work our way out of the job, which we do, what our job is to help them learn how to do better, right? And a lot of these, the parents that you deal with in child welfare, they've been so beat down by the system is that they don't believe that they can be successful. And so part of your job is to start working with them to be successful. Now, and I'm a big proponent of the Guardian Ad Litem because what you find is that's allowed to be the only person that's in that child's life, consistent person outside of the family that's in that child's life during the time that they're in child welfare, right? That they may have 2 or 3 case managers and whatnot, and they're the only one in court that's only interest is the best, is in the best interest of that child. Okay, everybody else, because when you look at culture, and the culture drives what everybody does, and each of these different agencies has a different culture of what they're trying to accomplish in the court, right? And the GAL's culture only is this child's best welfare, right? And so that's a critical thing. Now the other thing is that you got to work with the court to have a good relationship with them too. But that's the GAL. But I think the GAL can get that understanding going, and then you can you've got a pretty robust system of care group down in Miami-Dade.
I'm the program manager for the expansion.
Okay, well, you know who those people are. No?
Yeah.
And they've been doing this for a while. And you got Cindy Letterman down there, and she understands this stuff. And the best way.
In a few months.
Yeah, well, but see, down in that area, one of the best people to work with is Judge Letterman.
Yes, she is.
Because the other judges respect her, And she's been doing this children's court for a long time. You know, she's kind of the one that started baby court in Florida. And baby court is based on these same notions that we're talking about. Because we want to empower parents to raise their kids successfully. And the way you do that is by empowering those parents to be successful. All right?
So that's why I'm kind of surprised in the logos that we had up there. You had your community that's doing this are just children service providers. Do you work with the chambers? Do you work with?
Yeah, well, that's one of the things that we need to do better is reaching out more to different community folks.
Mm-hmm.
You know, getting the Chamber of Commerce involved, getting the Junior League involved and stuff like that.
Resources we're looking for,
Right.
employment for the parents, and also it highlights your community for those who are doing economic development because they can show up with the community cares about the children that
Yep.
created this.
Yep.
So,
And we're real fortunate. Sometimes things kind of come together at the right time. And right now we've got a mayor in Tallahassee that understands this issue of early childhood issues, this issue of early childhood economy, that he understands that. And he started the Families First initiative. And the person who he is kind of asking to really be running that and to designing what we need to be doing is Whole Child Leon. And by doing that with Whole Child Leon, he's also doing it with the PACT Partnership. So we're at a good point to start getting more into the community. The other thing we're doing right now is we have a couple of things that we're doing, but another one is that the Comprehensive Emergency Services Center, which is our new state-of-the-art homeless facility, and developing a child development center for those kids that are in the families that are experiencing homelessness. And when we looked, now our development center, child development center, is going to be from birth to 5. And when we did a point in time count last month on how many kids that meant, is we had a little over 100 kids in the Tallahassee area that were from birth to 5 years of age that were, in a home or a family that was experiencing homelessness. And so we've got a pretty good group to work with. Let's see, is there any, we talked a little bit about the family protective factors, and again, because we're running out of time, one thing I would, encourage you to look at it is the 6 dimensions as trauma reduction factors, and that's in your handout, that you have my email address there someplace, that if you would like to get a hold of me, if you'd like to get a copy of this,
Yes.
of this, can you read it?
Yeah.
Okay, well, in our brochure there for our PACT partnership is there on the, then you
the
can.
younger ones can read it. Those of us are, that spot's awfully tiny.
Oh, okay, great.
Send that to me.
But I think that, and I'm really just starting to understand how this all goes together, but it really does all go together. What you laughing about?
Because you do understand how it goes.
I know, but when you look at things like this, every time you do something, you understand it changes a little bit. It really does. But I think that if we really do want to make a healthier community, then we got to make healthier families, and when you do that, you make healthier kids. And that's really what this is all about, I think. Do you have any other questions? Because I think all that stuff is stuff you're going to have to read because we ran out of time. That's okay.
That's good homework. Thank you.
That is good homework. Well, thank you all for putting up with me for an hour. Thank you.